Thank you to all of those who have already joined us. We'll just give it a couple of more minutes to let other people come in from the waiting room, and then we'll get started. Okay, in the interest of time, I think we'll get started to give Dr. Narod as long as possible to answer many of your questions that you may have today. Dr. Narod has agreed to spend a lot of his time taking questions, so please type away your questions. If you haven't been on one of these seminars before, and you have a question, please type it into the Q&A tab at the bottom. And then at the end of Dr. Narod's session, Dr. Katsopoulos and I will go back and forth and read your questions to him, and he'll be able to answer those. So please do, throughout the presentation, enter your questions, and we'll try to get them all answered today. So I'm thrilled to be able to introduce Dr. Stephen Narod to all of you. Many of you may know him. Many of you may have seen him over the years, and it has been over 20 years of research that we've been doing at Women's College, and many of you may have been involved from the very beginning. So today, as you're aware, Dr. Narod is the director of our hereditary breast and ovarian cancer clinic at Women's College Hospital. He's a professor in the Dalla Lana School of Public Health at U of T and holds a Canada Research Chair in breast cancer research. He's also one of the most cited breast cancer researchers in the world. So we're thrilled to have him here today to share his insight into what we have learned and how this has changed clinical practice for women with a BRCA1 or 2 mutation. So welcome, Dr. Narod.
Welcome, everybody. Can you hear me okay? And
yes,
see the slides? Well, actually, it's this month I got a pin from Women's College Hospital for service for 25 years. So it's jumped up a bit. So we came here in 1995, but that wasn't the very beginning of the journey. It goes actually back a little bit further. And I'm going to sort of summarize quickly that journey that we've taken. Many of you have been involved. If we see the hunt for BRCA1 and 2 actually started in 1987. At the time, after finishing a brief stint studying genetics and public health at the University of Ottawa and here at University of Toronto at Sick Kids Hospital, 1987, I moved for a couple of years, IARC, International Agency of Research in Cancer in Lyon, France. Get the start working with a couple of guys, one Gilbert Lenoir, who ran the laboratory, and Henry Lynch, who was really the founder of breast cancer genetics, worked with us from 1987 until sadly he passed away 2 years ago. But Henry collected a large series of breast cancer families throughout the United States. We took blood for them and started looking for BRCA1 and BRCA2 using techniques linkage analysis. BRCA1, I think our first significant paper was in 1991, where we showed that after Mary Claire King discovered the location of the BRCA1 gene, we were able to show that it was also the gene for hereditary ovarian cancer, published in 1991 in the Lancet. I moved to McGill University as an assistant professor in 1990 from France, and I stayed there for 5 years. During that time, both BRCA1 and BRCA2 were discovered, the first 2 genes, in 1994 and 1995. And I was involved in both discoveries, largely using the families that Henry Lynch had collected, and we studied them. But being an epidemiologist and really a clinician and a physician, I became mostly interested in how are we going to use this information for preventing cancer or treating cancer. So I started back in 1994 with help from the NIH and from the MRC, a big study registering carriers. So we figured if we're going to learn about carriers, we're going to have to collect information on carriers. And many of you are in that study, which started in 1994 and it's been going ever since. In that time, the first grant we got was to find 200 carriers. Some said it couldn't be done. As of 2021, we've actually registered 17,000 carriers from all around the world with BRCA1 and BRCA2 mutations. You can see on the green line the number of carriers going from up to 18,000. And at that time, we started writing papers about it. First paper after the BRCA2 was discovered in the, I think the pink line, we're now about 500. No, the red line is the carriers, the green line is papers published. From using that registry, we've actually on BRCA1 and 2 published over 500 papers. So I can't go through them all. I mean, if you see some based on our international registry, I would say I just put in a few highlights. We've really struggled with this, is how to prevent it. It turns out we've really been able to do a lot of progress with preventive surgery, but our goal is to be able to find alternatives to preventive surgery so women may keep the breasts and ovaries and still have a healthy life and still have a good life, normal life expectancy. So the ongoing goal, I mean, at the time when I started in 1995, here at Women's College Hospital, I think our goals were to find preventions that didn't involve surgical removal of organs, and also to be able to make genetic testing cheap and accessible to all Canadians who wish to have it. And it's been quite a journey, and we've been successful, I think, in the second one. We've done a lot of research in the first one, but we still haven't reached that goal. I think one of the major findings was with where I think one of our colleagues in Joanne, to show that progesterone really was more of the culprit behind the growth of BRCA1 breast cancers. People had really thought it was an estrogen related thing, but it turns out progesterone looks like it's a key player. But for the first 10 or 15 years, we ran around the world, many of us, my students, me, collecting samples from all over the world. And I've actually been fortunate enough to work with all these countries in the red dots, and we did mutation surveys to see if we can find mutations in prevalence and surveys throughout the world. This took a good deal of our time. We've done studies in Asia. We actually did one in Mongolia, several studies from the Philippines, from Vietnam, and from Bangladesh. These are our Asian studies, but we've done many studies in Europe, good collaborations in Austria, Greece. We've actually worked in Belarus, done several studies in collaboration with Iceland, where they have a common mutation. Also in Lithuania and Scotland. Most of our work, our biggest collaborators, have actually been with the lab of Jan Lubinski in Szczecin, Poland, which has been a huge collaborator over the years. And I spend a month there every year, and we've published over 100 papers, largely due to the fact that there's a small number of mutations found in lots of breast cancer patients in Poland. We have studied throughout the Caribbean. We've gone in Jamaica. We've gone to the Bahamas. Bahamas has the highest frequency in the world. 22% of breast cancer patients in the Bahamas have a mutation. We've been to Trinidad and Tobago. We've been to Cuba. We have a long-standing collaboration in Costa Rica, in Mexico, and recently we did a survey of all throughout the Caribbean. We worked in South America. We've run papers and studied in Argentina, in Colombia, in Peru, and in Brazil. And even in Canada. I mean, in Canada, we look at specific populations, particularly in French Canadians. I started at McGill, we looked at French Canadians who have their own mutation. Jewish women have their own mutations. It's quite common. We worked throughout Ontario, screening for patients, Jewish patients. And in fact, we did the first study with Kelly Metcalf looking at unselected Jewish women, and it actually became a policy through that study that all Jewish women in Ontario were eligible for testing. And we did find mutations even in a small study in Native Indigenous families. So enough said about that. I mean, our basic goal, we got prevention, we got screening, we got treatment, we've got access to testing, and we've got survivorship care. Going quickly, in our ovarian cancer, we really, if you look at the bottom, where the gold standard is preventive surgery, bilateral salpingo oophorectomy, remove the tubes and the ovaries, reduces the risk of ovarian cancer by about 90%. We recommend for BRCA1 carriers a surgery done at age 35. We recommend for BRCA2 carriers a surgery done at age 45. We found other ways to reduce the risk, oral contraceptives, breastfeeding, and tubal ligation. are all associated with a favorable risk reduction. However, at this point, we don't have a real option for an alternative that's as effective as preventive surgery. So while we encourage oral contraceptives, breastfeeding, and tubal ligation, I don't think it's an alternative to having preventive bilateral oophorectomy. In breast cancer, we've been kind of less successful in finding really good ways. We find tamoxifen, there's an ongoing study looking at tamoxifen as prevention. It's hard, very few of the women are taking tamoxifen, but we found those who do take tamoxifen for breast cancer, the risk of getting a breast cancer in the opposite breast or the contralateral breast is reduced by about 45%. So that's encouraging. So we like to think if we gave them tamoxifen in the first place, we would be able to reduce the risk of the first breast cancer as well. Not yet, though, to say that's an alternative to preventive surgery, which is a patient's decision. We have about half the patients in our studies in Canada opt for preventive surgery as the primary management. The other half mostly rely on intensive surveillance with MRI. But at this point, until we can show something that's equally as effective, preventive surgery, preventive mastectomy remains the gold standard for breast cancer prevention. I just want to show an important study for hormone replacement therapy. Many of the women who do get their ovaries removed are offered, those not with breast cancer, but without breast cancer, will go into menopause if they get their ovaries removed before natural menopause. Of course, they may suffer from menopausal symptoms early. Sometimes it can be mild, but sometimes it can be more severe. So we recommend hormone replacement therapy, but according to this study, from about a couple of years ago, Joanne spearheaded this. What we see is a risk graph, which pretty well shows that if those took estrogen as hormone replacement therapy, those with two breasts, the risk of breast cancer was about 10% over 10 years, versus those who took a combined progesterone and estrogen, which was about 25%. And the risk for those who took estrogen only was in fact a little bit lower than those that took no hormone replacement therapy. This is why we're now focusing on progesterone blocking as a possibility of preventing breast cancer. Screening has been some success. We've found some success with breast cancer, less so with ovarian cancer. So this is, we had this is a continuing study. This is one of our last ones where we published papers in an Ontario cohort. We had 496 women. Now this is very interesting. 496 women with breasts were chose to have screening instead of preventive mastectomy. Of those 496 women, 57 developed breast cancer in the 20 years follow-up period, of which the majority were detected by the MRI. So the MRI was quite successful in finding the cancers. There were 4 deaths, which is a low number. We would have expected 2, but we got 4. So that's far fewer than for those women who didn't get the MRI. Nevertheless, we have to balance the fact that of those 496 women, 57 of them were detected with cancer and were going through treatment. These MRIs were done annually, once a year. Over the time, we found 57 cancers and 4 deaths. So the number of deaths, I think, might be considered acceptable. It's the patient's decision based on these numbers. Nevertheless, there were 57 cancers detected that might have been prevented with mastectomy. So it's really important that the patient understand the differences in surgical prevention, which is to prevent cancer, and it does highly effectively, and the preventing death, which is the ultimate goal. So we think the MRI, of course, it didn't prevent cancer. 20% of the women got cancer in 20 years. But we reduce the number of deaths. So that's something that should be brought to the attention of each patient making that choice. This is a study from Poland. I said we did a lot of studies. This one, we compared women who went for the opherectomy with women who went for annual screening with ultrasound, transvaginal ultrasound. So you can see at the left, of those that went for an opherectomy, there were 2 deaths. Those that relied on an ultrasound, there were 27 deaths. So that didn't look too promising, really. And when you looked at those 27 women who had ovarian cancer detected by ultrasound, these are women that went into the screening arm of the study and relied on the annual ultrasound to find their ovarian cancers. We found 20, well, in this case, we had 73, but 27 died, and the survival was really only about 30%. So we're looking for a survival, 80 or 90% to be able to really say that ultrasound is an alternative to prevention. You could see that of the women who chose to have screening instead of surgery, of those that did get the cancer detected, 27 died of ovarian cancer, which is far more than we would like to see. So we're no longer really advocating ultrasound as a really alternative to preventive surgery. So let's jump ahead and talk about treatment. Now we're starting to think really focusing on how women should be treated. We started with BRCA1 and BRCA2. We're expanding this international studies with 5 genes, BRCA1, BRCA2, and the 3 additional genes we studied, CHEK2, PALB2, and ATM. So this was one of our studies with Poland, where we followed a few, I think 300 patients, looking for survival. Again, the lines at the top indicate better survival at the bottom. And in this particular study, which is really one of the first and an early study, we looked at the effects of having an opherectomy, having your ovaries removed, not just on preventing ovarian cancer, but as a treatment of breast cancer. These women all had breast cancer, as well as the drug, the cisplatin drug, which we were the first to employ. And you could see of those that had an opherectomy and took cisplatin, their survival at 10 years was 95%. Of those who had an opherectomy without cisplatin, it was about 90%. Of those who had cisplatin without an opherectomy, was about 85%. For those women who had neither cisplatin nor an opherectomy, the survival was closer to 65%. So there was a big difference here. These are ongoing questions. People are still wondering about how these drugs are working and whether they're the drugs of choice for women with BRCA1 and breast cancer. But the opherectomy was quite surprising. And we followed it up with a study from BRCA2, an international study which I worked with over the past couple of years. And we saw a very similar effect. We saw on the left, those women who had an opherectomy had a 90% survival. Those women who didn't had a 60% survival. This is from breast cancer, not just from ovarian cancer. One interesting finding, I think, that is starting to be recognized is that in general, women with ER-positive breast cancers do much better than women with ER-negative breast cancers. BRCA2, they're split about half and half, but we found that there was no benefit, or there's no difference in the survival experience of women with a BRCA2 mutation, whether or not the breast cancer was ER-positive or ER-negative. PALB2 is a really mysterious gene. We're just starting to work on it, again, a Polish study. So we compared the survival of women in Poland with no mutation, 4,000 of them in the green line. Those with the BRCA1 mutation, about 300 and 400 of them in the blue line. And those small number of women, about 100 with a PALB2 mutation. And what we found was quite striking. Those women with BRCA1 mutations had a similar survival experience to those without a mutation, but those who had a mutation in the PALB2 gene did much worse, did quite poorly, in fact, and only about half of them survived 10 years. So we decided to expand that study in order to understand why that is. Is that based on treatment, or is that just a natural effect of the gene? Can we bring that red line up to the other lines by offering the appropriate treatment? So that's a study that we're now doing. I think Kelly Metcalf is leading that, funded by the CRC, funded by the CIHR. And we're really anxious to get that going, because it's really an unacceptable survival rate. And the sooner we figure it out, the better. CHEK2, the last gene I want to talk about. This paper was just submitted, a Polish paper comparing CHEK2 mutations to people without CHEK2 mutations. We matched 839 mutation carriers to 839 women with the same kind of breast cancer, but without a CHEK2 mutation. And you can see on the left slide, they really had pretty much the same survival experience. Not great, but it was 15 years. They had a 75% survival, which is about average. And you can see that it was not different for the CHEK2 carriers and for the non-carriers. But we did see, again, surprisingly, the survival was much better than that, was 86% for those CHEK2 women who had an opherectomy. Again, the ovaries are playing a role, which we haven't quite figured out yet. I should say that when we made the same curve for the women who didn't have a mutation, that there was no significant difference with the opherectomy. It does look like opherectomy is an effective treatment for many of these genes. In some women, it is in the general population, but it's far more important for carriers of these three genes, BRCA1, BRCA2, and CHEK2, than for the general population. We have not yet been able to tease out whether opherectomy is equally beneficial in women with the PALB2 mutation. Survivorship, many students and their colleagues have been working on this. So we know about opherectomy. We are recommending it to young women at 35. We want to know what it has how it affects their quality of life. We did see some decline with an opherectomy, particularly in bone health with our colleagues at Princess Margaret. We saw a decrease in sexual functioning and an increase in menopausal symptoms. But we did not see an increase in cognitive impairment, that's memory and intention. The women reported their quality of life was the same. We didn't see an increase in weight gain, nor did we see an increase in depression or anxiety associated with an opherectomy at a young age. So now how do we translate this knowledge? You know, I said one of our goals was to get this information to as many people as possible, but that involves making many people as possible tested. So we've engaged in the SCREEN project, which is a Canadian national study to offer accessible genetic testing for BRCA1 and BRCA2 and these other genes now to all men and women about over 18 that wish to have it without the necessity of having a genetic counseling referral, without the necessity of having a physician referral. They can go to the website of the SCREEN project, sign up, they'll get a kit mailed to the house, we spit in it, and they send it back to the lab. Now, this isn't covered by the government. The cost is borne by the patient. The cost is now $250 per patient, which is certainly, I think, is maybe a barrier to some women. We like to reduce that barrier, but the idea was to get fast and accessible testing to all Canadians who wish to have it. Their choice whether or not they wish to have it, of course. So they get online educational materials in the SCREEN project. They join the study. They pay $250. They send their spit to the laboratory, get the results in 2 to 4 weeks. So really the purpose was to translate this, bring genetic testing accessible to all Canadians. It's a partnership with Invitae Laboratory in the United States. Any new breast cancer patient can self-refer. So if you've been following the talk, you see why we think that it's important to know your BRCA1 status at the time of your diagnosis. So we wanted to make that opportunity available to any woman in Canada with a new case of breast cancer, and she can self-refer to the SCREEN project. We'll have the results in a couple of weeks, usually in time to make her choice about treatment. The first 1,269 women and men that were tested, we found 14 BRCA1 and 16 BRCA2, about 2% were positive. Now we've entered the second phase, so far 349 patients tested. The second phase was characterized by adding a bunch of other genes, which was at the patient's discretion, or the women's discretion. So we find genes in BRCA1, BRCA2. In addition, in CHEK2, I don't think we found a gene in PALB2, but we do see them in ATM and in CHEK2. So just saying, so this was really an opportunity both for our research team to expand our scope to make sure we can get research patients involved and collaborators involved from all over Canada, from all over the country. And it's been a slow going 25 years, but I think we've made a bit of progress. And I think that's really a wonderful thing. Our team has really been together, I think, probably 20, 25 years. I've been at Women's 25. I think Kelly and Joanne's 15 to 20, and Mohammed Akbari, who's running our laboratory studies and our genetic mutation analysis, who has been joining us for 15 years. So this has been a great time we've had together. We've had a lot of fun. We've had a lot of disappointments, but we've had a lot of encouragement, and we've had a lot of cooperation from our colleagues. And I want to really thank all the participants in our studies who've gone the extra mile to help us fill in the questionnaires, stay in touch, give us access to their information and their medical records, so that we can really, as closely as possible, really get into their lives, their lifestyle, and know what it is that's going to make a difference. So I think our main transition has been really going from risk and prevention. Now we're focusing on knowledge translation and looking for the best treatments to offer women with hereditary breast cancer genes. It's really been many collaborators throughout the world, particularly our colleagues in Poland have put in an enormous amount of work. We have colleagues throughout the United States, Canada, Europe, and elsewhere. And there's a little picture of our team here at Women's College Hospital. I want to thank you for listening, and for those of you who have been able to go on this incredible journey with us since 1995. And we're hoping it'll continue till we get to the bottom and answer all of the questions. So having said that, I'm not sure the time is, but let's open it up to the floor. And if there's any questions, I'd be happy to do my best to answer them, although there's still a lot of questions, which I'm sure I don't know. Thanks.
Thank you, Dr. Narod. That was an amazing overview of all the progress we've had in the last 2.5 decades. And it's definitely showcasing what a team effort this large longitudinal study has been. So we have a lot of questions. I read many questions. I really don't even know where to start. So there was a lot of questions I think I can lump together on screening or management following preventive surgery. So it seems like a lot of the women here have posted that they've had preventive opherectomy and mastectomy, and they're curious as to whether or not they should still be followed with respect to having MRI imaging or any other sort of imaging.
Yeah, that's a good question. So certainly after preventive surgery, is there still a, I guess the question is, there's two parts to it. Is there still a risk of cancer that's important? And is there something you can do about it by screening? I would say for breast cancer, for those women who have had a breast cancer, a bilateral mastectomy, and to have no cancer detected in the breast, that is pathology, we don't recommend MRI. In fact, the reason is the risk for them is less than it is for the women in the general population. After a bilateral mastectomy for a BRCA1 carrier, the risk for breast cancer is probably close to 1 or 2%, whereas the average women in the general population with the risk would be about 7%. So in fact, you're doing well, the risk is lower. And so we wouldn't recommend for a carrier after a mastectomy because we don't recommend it for the average woman. The situation with ovarian cancer is a little different. The average woman in the Ontario has about a 1.5% risk of having a ovarian cancer to age 70. The risk for a BRCA1 carrier is about 40%, and the risk for a BRCA2 carrier is about 20% if their ovaries are intact. After we remove the ovaries, there is a residual risk. That's why it's not 100%. There is about 3% for BRCA1 carriers to get what we call peritoneal cancer, and it's about 1% for BRCA2. So this 3% risk of peritoneal cancer, which looks like ovarian cancer but occurs in women after opherectomy, is low. If I had evidence that screening for that with CA125 would reduce the mortality from that, I would recommend screening. At this point, we don't really have the evidence, even though the risk is relatively high. It's not great, but 3% is nothing to ignore. We don't have the evidence that screening, ultrasound, or CA125 will pick it up early where it's a more curable stage. Tough study to do. So I would, I think it'd be a lot left to the individual women and their gynecologists. If they wish to pursue an annual CA125, I would not discourage that, but I'm not in the position with the evidence that I have to make it as a solid recommendation.
Great. Thank you, Dr. Narod. And there are numerous questions about some of the other genes that you've talked about today. So PALB2, ATM being mentioned. So I'm going to ask a few questions together, and maybe you can bring it all together for everyone. These are newer genes. We know less about them, especially the clinical implications. But can you tell us about PALB2 in terms of the breast cancer risks? When should, if a mother has a PALB2 mutation, when should her children be tested? When should her children start breast screening if she was diagnosed with a breast cancer in her 20s? And if someone has been tested and found to have a BRCA1 or 2 mutation, should they now be being tested for some of these other genes as well? So a lot of questions in there, but
Okay, so the second question is relatively easy. Currently, genetic testing in Ontario and in the SCREEN project, you'll notice, currently testing in Ontario, and I think throughout most of Canada, looks for all the genes at the same time. You know, how many genes on that panel? Like 20 genes. So anybody going today for a test, with the exception, I think, possibly of some Jewish women, anybody going for testing today in Ontario gets all the genes tested. So if you had 2 genes, we would find out. It rarely happens. It rarely happens, but you would know. We don't go from testing one to testing another. There are some patients in the past. We are mostly concerned about patients in the past. And if anybody's there in the audience who had testing only for BRCA1 and BRCA2, we would recommend that they get updated testing for the rest of the genes. But we don't currently test first for BRCA1 and 2, and if nothing happens, we go to the next panel. We do them all at once. But it's important, I think, for anybody who has family history or personal history of breast cancer to go for the other genes. I should say, importantly, the main difference between BRCA1 and BRCA2 is a higher risk, but also ovarian cancer. When we don't talk to BRCA1 and BRCA2 carriers without mentioning both ovarian cancer and breast cancer. The other genes do seem to be more breast cancer specific. And you know, whether they should, and for most of them, and rare exceptions, we have not made recommendations for removal of the ovary for people with CHEK2 mutations, with PALB2 mutations, or with ATM mutations. So that's really more of a discussion. I should say for individuals like the woman who says her breast cancer was diagnosed at age 20 with a PALB2 mutation, that is a very specific case. It's something I would look at closely, not something I would feel comfortable about offering clinical information recommendations in a forum, but would recommend a really detailed discussion with physician and genetic counselors. And I'm always here to help for those individual cases if anybody wishes to. But I would, that's a very, I wouldn't say difficult as much as that's that's quite a dramatic presentation. It's very rare to see a PALB2 woman get a breast cancer at age 20. So if it's hypothetical or real,
28, I think, but still
28, but still rare.
Yeah.
We would look at the family history, we would look at other things that we'd make recommendations. Now, PALB2 is different from BRCA1 and BRCA2. We think the risk of breast cancer for BRCA1 is about 70% to age 70. We think the risk of breast cancer for BRCA2 is about 60% to age 70. We think the risk of breast cancer in PALB2 is about 30 to 40% to age 70, which is about half, so it's intermediate. Is that risk high enough to warrant a preventive mastectomy? Should we go with screening? The jury is out. There's certainly a woman at 30, 40%. I would certainly entertain a wish to have a preventive mastectomy, but we don't routinely offer preventive mastectomies to people in the population with risk of 30%. Having said that, the caveat there is the mortality is much higher. So even though the risk of getting breast cancer is higher in BRCA1 and BRCA2 than PALB2, the risk of dying from it is almost the same, because of very high mortality associated with breast cancer and PALB2. So I think when those numbers are taken into consideration, the woman should ask her doctor when she's looking for that information. Yes, doctor, but what if I get a BRCA breast cancer with the PALB2 mutation? Are you pretty sure you're going to find it at a time where it is curable? I wish I could say yes. I don't think we have that evidence yet. That's why we're doing this study, and I want to get it done as fast as possible, because that's probably one of the questions on top of our list. How can we, is the risk of that mortality that high? Is that from our early studies we'll be convinced? And what can we do about it? Opherectomy is your special kind of chemotherapy that we need to investigate.
So can I just follow up on that, Dr. Narod, and just say to those who are listening today who have a PALB2 mutation or an ATM mutation, we are starting to look at these genes very carefully in terms of how these breast cancers should be treated. So please be in touch with us and we will include you in those studies. We need as many women as possible in these treatment studies to figure out how to best treat these breast cancers. So please be in touch with us.
And are you talking also without cancer?
Yes, so we're opening up risk factor to some of these other genes as well. So it's going to be important. Many of the questions that we were thinking about 25 years ago about BRCA1 and 2, we're now in that same position with some of these newer genes like PALB2 and ATM. So
yeah, we got them. It's a collaborative effort between us and you. I mean, every study I presented today was due to women who volunteered the information. We didn't get the information by looking at charts. We got the information by talking to women and filling on a personal one-on-one basis. 17,000 individual women filled in our questionnaires. So, I mean, it's a collaborative thing. In other words, we do depend. And I mean, having said that, I think we've had great participation and I've enjoyed every minute of it. But, to go forward, the other thing, Kelly, is PALB2 mutations are rare. Yeah. I mean, they have quite a severe impact, but we want to get 500. Mm-hmm. And, to get 500 PALB2 women with breast cancer, we got to scan far and wide and hope for really good cooperation between laboratories, between individual doctors and clinicians, and also the patients themselves. So it's really important that, I think about a third of the patients that are now signing up for the studies just come to us directly and are not being referred. I think my favorite emails of the day are the ones I get from someone in the States says, "Oh, doctor, we got one today. I found I have an ATM mutation in breast cancer. Do you know what to do? And is there any studies I can join to help?" Those are the emails that I love.
Mm-hmm. And many of you who are here today are participants in this study, and we are thankful because it's your commitment to filling out those questionnaires that helps us conduct these studies. Mm-hmm. So just as a follow-up, because it seems like there's some confusion with the updates and testing. So for those who were identified to have a BRCA1 mutation, 10, 15, 20 years ago, that you are a mutation carrier, so you would not have to be retested. But for some of you who might have tested negative a decade or two ago, and you do have a strong family history or want to be retested, you should go back to your genetic counselor. And
that's correct. I mean, the things that can happen very rarely. I don't know, one can a mutation be? We do recommend those who are tested in the research lab to be retested in case of sample mix-up, which is very rare. More importantly is if the person tested negative, that they get updated is there more genes to test? In particular, there's been a change in your family history. Let's say a sister or a daughter got breast cancer, that would really be worth another look. And we also have more genes to test. And there are occasional examples, rare, where in the old days, a mutation, I should say there were old techniques, sometimes mismutations, the newer techniques might be better. And there were times when mutations were considered to be not pathogenic, not serious, and they've been reclassified after as pathogenic. That happens very rarely. Having said that, I mean, these are relatively rare occurrences. When we went back and tested a lot of women for mutations that were initially negative, we found only a few. So we do find a few, but it's rare. I would say, though, the main ones, in my opinion, the main three genes to be tested for are BRCA1, BRCA2, and PALB2. Those are the ones that carry the most weight. PALB2 is quite rare, but it certainly is a serious one. CHEK2 and ATM, we're finding a lot of them. The risk of breast cancer is higher, but it varies, and it's not in the same neighborhood.
Okay,
Okay.
thank you. So there's also some questions about hormone replacement therapy. If this applies equally, I mean, this gets complicated. If this applies equally to women post, whether or not they have had an oophorectomy, whether or not they've had breast cancer. Do you recommend against progesterone HRT, therefore needing hysterectomy along with oophorectomy? So these are all very important, complicated questions.
Yeah, those questions should be brought up, I think, with the gynecologist. As a rule of thumb, the first rule of thumb is we generally don't offer hormone replacement therapy to women with breast cancer, particularly if it's estrogen receptor positive breast cancers. There are some doctors who provide estrogen therapy to women who have had breast cancer if it's ER negative. It's not the standard of care, but we certainly recognize for some women the symptoms of menopause are pretty severe and are not alleviated by means other than estrogen replacement therapy. But generally, we do not recommend estrogen replacement therapy to women with breast cancers. Among those women without breast cancer, I mean, we look at natural menopause and surgical menopause. We're under the impression, although it's probably an impression, that those women who have surgical menopause, that is, let's say at age 35 after going an oophorectomy, may have a more acute, rapid onset of symptoms. The symptoms may be most severe, and they may really wish to have a alleviation of those symptoms of hormone replacement therapy. My personal recommendation is to take estrogen alone when you can. Estrogen, progesterone, we're still working out the details, and seems to increase the risk of breast cancer. If you've had a bilateral mastectomy, I don't think it matters whether you take estrogen alone or estrogen plus progesterone. If you have had a hysterectomy, a bilateral oophorectomy with breasts intact, I think estrogen is a better choice than estrogen progesterone. In general, we recommend a progesterone when the uterus is still intact. Some women have an oophorectomy and leave the uterus intact. It varies a lot by doctor. There's those women, the doctors tend to avoid estrogen alone and give estrogen progesterone. So it's complicated.
And to clarify, a hysterectomy is not necessarily, it is not standard of care when you're having a bilateral oophorectomy. So like Dr. Narod mentioned, it's something you have to discuss with your gynecologist or gynecologic oncologist. It's an important decision. It's a more intensive surgery, but it will affect what type of hormone you're eligible for afterwards.
Okay, there are a few questions about mothers who have BRCA mutations and thinking about their children. First of all, when do you tell your children? What age should those children be tested? And at what age should screening start for those children? So thinking about the children in their 20s, I guess.
Well, we have a pretty standard in Ontario recommendations. I don't make it the Ontario breast cancer screening. For screening, I'm not I mean, MRI starts at age 40, 30 for BRCA1 and 2. So basically, when would knowledge of it change the practice? Certainly at age 30, you would be offered an MRI. We generally don't recommend testing under age 25. I think age 25 makes sense. But if the woman wishes to know at 18, she's an adult and she's eligible for testing. If an 18-year-old woman came to me and said, can I get tested? And she had a mother with a mutation, yeah, we say, sure. We may say, well, you can wait till age 25 if you like, but it's up to her. I'd say half of them wait, half of them do it at age 18.
Mm-hmm. It's really dependent on the child, I would say as well.
Yeah.
Yeah. Okay, Joanne?
Sorry, I was on mute. Oops. Can you hear me now?
Yes.
Yeah.
So you alluded to this near the end of your presentation on the studies that we're doing on post-oophorectomy health. And there's some questions about maintaining bone health, heart, cardiovascular health. I know you spoke about it. Do you have any of your own recommendations? I know a lot of this would require you to be have frank discussions with your general doctor on maintaining bone health. We're not seeing a negative impact on certain factors such as cognitive health, but Dr. Narod, what about your suggestions?
Well, certainly the one that's the clearest is bone health. We've done studies, I think you did it more than me, where we just looked at bone density and found that we did see a decline after the oophorectomy. I would certainly recommend everyone to get a bone density test after an oophorectomy, maybe before and after, to see if there's any change in the urine to be followed appropriately. I'm not the expert in how to treat osteopenia, but it's something to be checked for sure. One thing is, though, we haven't followed the women long enough, you'd think 25 years, to be able to really ask those questions about the long-term incidence of fractures, heart disease. I would also suggest that anybody who has an oophorectomy get the baseline workup for lipids and for blood pressure and for diabetes to see if there are any other risk factors for heart disease. I have to say, though, we have not seen in our studies any kind of an impact yet on heart conditions. Maybe their women are too young. Maybe we haven't followed them long enough. It's something that we hope to do, but may have a challenge in doing so. I think it's certainly worthwhile probably to think about what should be a standard thing, whether you need to do it at 35, 50, 60, whatever, what those tests would be. But there were some studies, I think, in mice and in others suggesting there may be a heart effect. We haven't seen it in our patients. Having said that, in the general population, I believe from the Nurses' Health Study and from the Women's Health Initiative, they did see some cardiovascular, cardiac side effects of early onset menopause. So it's something to be concerned with. We're not concerned with it to the point where we recommend against it. I don't think I've ever had a patient in my practice who has a BRCA1 mutation, and correct me if I'm wrong, that I've recommended against the oophorectomy. I don't think I've ever said to patients, well, oophorectomy is a general recommendation, but in your case, I wouldn't do it. You have too many other factors that may influence your health.
And as Dr. Narod already mentioned, oophorectomy not only prevents your disease, but impacts your overall survival. And also some of these other outcomes that we're talking about, like bone health and heart health, your family doctor should be able to follow you, and he or she will treat you as someone who is menopausal. So you would be eligible for a bone density, and I'm sure they would counsel you on appropriate vitamin D and calcium intake.
Great. Okay, we have a question here for a transgender person who's gone from female to male with a BRCA1 mutation, has had preventive breast removal and an oophorectomy. Is there any data on cancer risk associated with taking testosterone?
Well, in the general population, there is mixed data. I mean, some breast cancers do have androgen receptors. There's been emerging data on androgens, natural androgens, circulating androgens, which in women come from the adrenal glands and from the ovaries and from supplement.
Mm-hmm.
However,
with a preventive mastectomy.
With a preventive mastectomy, I would, no expert, I would not see the androgens be contraindicated in a BRCA1 carrier with a preventive mastectomy.
Mm-hmm.
We've had it. So that case, I think, is relatively easy. I have had, here's an analogous question for some women after the oophorectomy experience lack of sexuality, lack of sexual libido interest, and hormone estrogen and progesterone don't seem to alleviate that. The only real treatment for that, as far as I know, I'm no expert, is testosterone. Testosterone given to women post-oophorectomy is the treatment of reduced sexual libido. So those women with the BRCA1 mutations and breast intact, I'm kind of nervous about it, but we don't have any evidence.
Mhm.
That actually comes up quite a bit. Joanne, what's your take on that? Testosterone as a treatment of menopausal sexual.
Again, I am not a clinician, so I'm not going to give advice. This is why you need to speak to your clinician who's taking care of you post your preventative surgeries. And for example, we have a great integrated clinic here where you would meet or see a gynecologist with a specialty in menopause management, but it really would depend on the individual, right? Whether or not they've had breast cancer. So hormones.
No, I'm just thinking about is testosterone a risk factor for breast cancer in general?
In general, I'm not sure it's as strong as the other sex hormones.
Okay.
I can't comment on BRCA mutation carriers. We've not looked at testosterone.
But I would say for someone who's had a bilateral mastectomy, my fears would be alleviated.
Yeah.
But I'm talking about the concern of a testosterone that's causing breast cancer. I don't think it has anything to do with any other kind of cancer. So if you had a bilateral mastectomy, I think you're safe. There aren't any other, I have no other concerns about testosterone, but I'm not desperate. Go ahead.
Joanne, I'll go. Do you want me to ask another quick one?
Sorry,
About-
I'm still going. A lot of them were
Yeah.
about bone health.
The age of oophorectomy, you said 35. Is that different than a 35 to 40-year-old or 40-year range?
Oh, the fact that our group recommends 35 and CCN says 35 to 40. So for a
Those
young
aren't really
woman,
big differences. We base the 35-year-old risk on two things. And this is evolving, and this is based on 17,000 women. So where do I get the 35? I get it from two facts. We looked at whether or not they had ovarian cancer in the ovaries that nobody saw at the time of the oophorectomy. Overall, we found 5% of the women who went to get their ovaries removed, we found cancer in the ovaries, and those are now cancer patients. So 95% of those patients, we said, yeah, we took your ovaries out, we don't see anything, you should be okay. 5% of the women that went for an oophorectomy were told, yes, we found a small cancer in the tubes or the ovaries. Now, under the age of 35, I only saw it once in thousands of women. Between the age of 35 and 40, we saw it, I think, 10 times. Under the age of 35, we almost never see that. So if you get it at, if you get it at under 35, I mean, I could go almost as far as saying you don't even need a pathology to review it. You're not going to find anything. The second line of evidence is among those 17,000 women, this isn't published yet. It's taken me 20 years to do this study. We had, of the ones that about 6,000 who had their oophorectomy, 52 of them got a peritoneal cancer after the oophorectomy. So 52 women of 6,000 that went for an oophorectomy, about 1% got cancer after the oophorectomy. Nobody who had the oophorectomy under 35 got it. I mean, there is, if you really want to wait till age 40, the risk is small, and it might be a trade-off. It might be a trade-off. But if you ask me, Dr. Narod, I don't want to, what's the most I want to prevent everything I can. The thing would be oophorectomy at 35. Now, there's two reasons not to do it. One is you want to have kids, and one is you don't want to go through menopause. And those are valid reasons. I would feel comfortable to make that discussion with any women about the pros and cons of an oophorectomy at age 35 and age 40. If a woman age 45 came to me and said, can I hold off on the oophorectomy for another 5 years till age 45, I would feel very uncomfortable.
Mm-hmm.
So I think the 35 to 40 is a really good, I mean, I'm not disputing that, right? I think we're both on the same page. 35 would be the ideal, 40 would probably be my upper limit.
And so this is for BRCA1. BRCA2, the
Yeah,
age
that's
is
right.
a little bit later.
You can wait till 45 with BRCA2.
45.
We almost never see ovarian cancer under age 45. I don't know why that is, but the more we look, the less we never. I mean, I got maybe 2 cases, ovarian cancer under 45 in BRCA2.
I think in our study, we had no cases under 45.
Yeah.
Mhm.
So we're coming near the end, and there's a lot of questions on.
Well, I don't mind saying another 10 minutes. I don't know,
Okay,
it's up
well,
to you.
Okay, well, let me just answer. There's quite a few questions on participating in our studies, which is great.
We'll answer those.
We value those a lot. Unfortunately, there's nowhere for me to message. So there is an email you can email, or you can check on the Women's College website.
So why don't you just put the email in the chat?
There's no chat box here. I'm
No
trying
chat box?
No.
We can include that when we send out the evaluation.
Yeah, do that. That'll be
Yeah,
great.
That we'll all receive. In addition, we're also asking you if there are any topics you would like to see a seminar cover, things that we haven't yet covered. Many of the talks that we've already given, including there was a question on the use of PARP inhibitors. There was an entire talk given by Dr. Eisen on that, and it's up on our website. So please make sure you look at some of those past talks if you have something of particular interest, but also let us know what else you'd like to hear about, and we will find the appropriate speakers to come and give those talks.
And just to reiterate, our website does have contact emails. The email to participate is Narod Study, NAROD STUDY @wchospital.ca. But again, we can circulate that, and it is on our website at Women's College Hospital. Okay, so Dr. Narod, you're willing?
Sure.
Let me see.
Would you do an oophorectomy at age 20 to 25? Stephen?
What's the question?
Would you do an oophorectomy between the ages of 20 or 25?
Well, I don't do them, but I would discourage
Would you
them.
recommend it? Yes.
To whom?
It's not specific. It
I
just
think okay, the question, I wouldn't for a healthy woman. This data, which I showed on the treatment, which is evolving for BRCA carriers with breast cancer, it's pretty early and it's only our studies, and I want to confirm it with larger studies. If the data holds up on the reduction in the mortality from breast cancer for BRCA1 patients with breast cancer associated with an oophorectomy, and if the woman had a breast cancer that would be node positive, let's say, and was at age 25, I think I would raise that discussion. But I think I would limit that discussion to women with breast cancer.
Mhm.
It's currently not done.
No.
Well, I mean, there are various reasons, but certainly the idea of you doing an oophorectomy for people with BRCA1 mutations usually talked in the context of preventing ovarian cancer. I
Mhm.
think we need to get, really focus in on that study to make sure we have everything in a row, how effective it is as a treatment for breast cancer. And as the slides show, we saw BRCA1, BRCA2, and in check to an effect. And then I was, it's a tough study to do, but I was encouraged by the fact when we ran the same analysis and matched controls without the mutation, we didn't see an effect.
Mhm.
But it's a really important question.
Okay. I don't see any other questions coming in.
Okay.
So thank you so much, Dr. Narod. There's a lot of comments here that it was an amazing presentation, very helpful. And we'll continue to do the research so that we can bring it back to you, the people who will benefit from this information. So thank you.
It's always a pleasure. Maybe next time we can do it in person, although I think a lot of people are probably not in Toronto. So maybe this idea of doing it over Zoom gets a wider audience.
Yeah, it's nice. It's nice.
Okay.
So we have one more seminar coming up next month. We don't have the slide up, but it's about talking to your children. So there were some questions today, and our social worker in the Peter Gilgan Center for Women's Cancers, who see many women with some of these genetic mutations, it's something that she gets asked a lot. So she will share her insight in some of the research that's available to guide the evidence that is provided to patients in this situation. So keep your eye out for the email. Please remember to fill out the evaluations and let us know what else you'd like to hear about as we start to think about sessions for the new year. So thank you, everybody, and have a good day.
Thank you.
Bye.
Bye, everybody.